Welcome, everyone. We are going to get started. My name is Matt Martin, your moderator for today. I am a clinical and research associate professor in the College of Health Solutions at Arizona State University and associate director of the Safety Net Advancement Center at ASU. And in the spirit of today's theme and topic, I just wanted to share that my parents have 7 adult children who are ready to help with caregiving and life planning when needed. I'd like to thank you for joining our Health Talks webinar brought to you by the College of Health Solutions at Arizona State University. Our college works to address the challenges facing people and communities to stay healthy, improve their health, manage chronic disease. These health talks are one way we serve the community with timely and relevant educational information that also provides continuing education credit at no cost. Before we begin, we have a few quick housekeeping items. First, this session is being recorded and will be posted on our website, asuhealthtalks.com. After the main presentation, we will have about 20 minutes for Q&A. Please submit your questions using Zoom's Q&A feature and not the chat box. Regardless of whether or not you have requested CEUs, please register your attendance using the self-check-in link posted in the chat so that we have an accurate record of who attended today's webinar. Finally, those of you attending live will receive a brief survey asking for your input about today's webinar. If you are requesting CEU credit, this must be completed in order to receive the credit. If you did not apply for CEUs, we would still appreciate your feedback to improve our series. I am so excited to introduce today's speakers, Barry Jacobs, Katherine Mahon, and Kimberly McGuinness. Barry Jacobs is a clinical psychologist, healthcare consultant, and former family medicine educator. He is the author of 3 self-help books for family caregivers, including one for AARP, and has been a columnist on family caregiving for the AARP website since 2013. He's also a board member of the Caregiver Action Network, one of the nation's leading advocacy and support organizations for family caregivers. Katherine Mahon is a family doctor at Penn Medicine, Chester County Family Medicine Residency Program. She has worked in graduate medical education for over 10 years, and her clinical interests are addiction medicine and care of vulnerable populations. Kimberly McGuinness is a board-certified adult nurse practitioner in primary care and faculty at Rutgers University School of Nursing in Camden, as well as a doctoral candidate at Rutgers University. Kimberly completed a fellowship in complex care and social needs with Crozer Keystone Family Medicine Residency in partnership with Camden Coalition of Healthcare Providers. She has spent the last decade delivering care to vulnerable populations, working to close gaps in care and improve quality of life for patients with chronic conditions and complex social needs. We are so fortunate to have these health experts with us today as we explore when clinicians become family caregivers. Clinicians who become the family caregivers for their own family members often find themselves in an ambiguous role. Sometimes their family members' health care teams welcome their input. Sometimes they resent it. Their own family members may want them involved in care, but not always. During the webinar, our presenters will talk about their own experiences as the family caregivers for parents with neurodegenerative conditions and share ideas for how clinicians can best engage healthcare team members while empowering their family members. So to start off today's group presentation, please welcome Barry Jacobs, and I will turn it over to you, Barry. Thank you.
Thank you, Matt, and I can call you Matt because you and I have known each other for probably 15 or 20 years now. So, but thank you, Dr. Martin, and really thank you all for being here. It's really a pleasure to be here with my former Crozer Health colleagues, Dr. Mahon and Kim McGuinness. And as you heard, the presentation today is about when clinicians become family caregivers, and we're gonna talk a little bit about our own experiences in that regard. And we really welcome your thoughts about maybe your experiences with being a caregiver for your family member, and bringing being in what we're going to describe as a clinician caregiver role. So here's what we hope to achieve during this health talk today. We want to describe the conflicted feelings of healthcare professionals who become family caregivers to their own or ill or aging relatives. And you'll hear more about those conflicted feelings in a moment. And then we'd like to define the ideal role of clinician caregivers as part of the healthcare team and list 4 strategies for those clinician caregivers to better partner with collaborative team members. Sounds easy, but in practice, it's not. So let's start with get right into it with Catherine.
All right. Good afternoon, everybody. Thank you for having us. So I'm going to start off with a story about my father. So this is a picture of my father, Ed. It's a picture of him probably about, maybe 6 months before he died in 2020. But he was diagnosed with Parkinson's at age 67, although it was probably affecting him for years prior to this, looking back. And he did well for several years after his diagnosis, but the last 6 to 12 months of his life were difficult, and he had a decline both functionally and cognitively and lost a good amount of weight. So one day, I remember it quite vividly in January of 2020, I was seeing patients and I got a text message from my mom to myself and my two brothers that my father had stopped swallowing anything. He had dysphagia for a long time, but he abruptly stopped being able to swallow any pills or any medications. So my mom took my dad to our local hospital after we discussed it. And this hospital is closed now, but it was actually in the network of hospitals where I worked and was close to my office. So I decided I needed to leave work. This was sort of an urgent moment. I went to my father's lawyer's office, sort of a family friend, and obtained a copy of his living will. It clearly stated that he didn't wish to receive heroic measures at the end of his life, including artificial nutrition. So in the ER, he had a chest x-ray that showed he had a mild aspiration pneumonia, but we really knew more than anything it was his advanced Parkinson's that was causing his inability to swallow more than something that would be reversible. So it was decided that he would be admitted to the hospital. The hospitalist came down to the emergency department to do the admission. And my dad, although, was suffering from some cognitive impairment, he was verbal, he was completely conversant. He was able to understand the situation, what was going on. My mom was present too, and she never worked in healthcare, but she was very health literate. She was really able to spout off all of my dad's medications without looking at a list, his last appointment, procedures, etc. But when the hospitalist came down, she really only talked to me. And in fact, much to the consternation of everyone, she only made eye contact with me. And at one point, she started whispering to me about whether my father should go on hospice. So at this point, my dad's lying in the gurney in the hospital, and he starts kind of like signaling over to me and saying, "What are you two talking about?" And at this point, I stopped talking to the hospitalist, went to the head of the bed, and essentially had an end of life discussion with my father, explained to him that his Parkinson's had progressed and the only option would be a feeding tube. He said quite clearly he didn't want the feeding tube and agreed to go on hospice. So that's sort of the beginning of my story. I'm going to pass it over to my colleague.
Thanks, Catherine. Thank you all for having us today. So this is a picture of my father about 2 years before he passed away. He was diagnosed with Parkinsonian dementia 5 years before he passed away at the age of 69. He was a Vietnam War vet and lived with my mom in the house I grew up with until a month before he passed. I had spent the previous decade working as a travel nurse and going to grad school and had been home for less than a year when I knew he needed to be evaluated. It was another 8 months before we walked into the neurology office together. Watching his neuro exam was probably one of the hardest things that I've ever had to do, but it's also made me much more empathetic to family caregivers. My dad quickly went from being our unofficial town mayor to nonverbal. He was a proud father that turned to me, his daughter, the nurse, for most of his decisions. But this was challenging. I was raising a family, working. I wasn't attending all of his appointments, and trying to translate the visits via my mom and dad's interpretations. And then to make it more awkward, my sister was working for a neurosurgery office and was also living with them at the time. He did make things rather easy, but this was also mentally challenging when he would just acquiesce to everything that was asked. Even the day I asked him to stop driving. And while this sounds ideal and probably what most people are hoping for, it was only another sign that my father was gone and the man that remained was his shell. And I'll pass it over to Barry for the beginning of his story.
Thank you. Thank you, Kim. So here's a photo of myself and my mom about a month before her death from vascular dementia and complications of kidney failure. My mom, during the years that I was providing care for her, which is all told about 7 years, she was a very proud person who did not want care, and she resisted my being able to help her, even though she needed quite a bit of care, both physical and cognitive support. One of the things that would happen invariably is I would accompany my mom to her doctor's appointments, particularly her primary care doctor's appointment. And my mom and I would argue in front of the primary care doctor. I would say to the primary care doctor, you know, my mom's been having falls and I'm very concerned about her. And my mom would then immediately get angry that I was saying things that she did not feel were true. So she would say to her doctor, I did not have falls. I don't know what he's talking about. And as you could imagine, the primary care doctor would look at us and say, well, you know, he couldn't make hide nor hair of what to do with us. And that this became a kind of ongoing point of conflict until we worked out a different arrangement. And the car ride home after my mother and I, she would have these appointments. My mother would just kind of rant at me in the car that how dare I try to take over her doctor's appointment. And when this was her doctor and she should have her private relationship with him. So I will leave my story at that juncture and go on to the next slide where we kind of give some of these a little bit more context. But before we do that, we're hoping that you can use the chat feature, or if not that, the Q&A feature to talk about maybe if you have been what we're calling a clinician caregiver, having that experience of caring for a family member and with the healthcare background that you have. Um, how would you rate your collaboration with your loved one's treatment team, where 1 is poor and 10 is excellent? So that would be the first number on a 1 to 10 basis. You know, how did it go with your loved one's team? And secondly, how did your experience go with playing the role of a helper with your family members? 1 was poor and 10 is excellent. And when I say family members, it's not necessarily just a care receiver, but all your family. Did your family look to you as an expert in guiding the family during this time of medical distress, or did they not want you to be a clinician? Did they just want you to be a family member? So I'm going to take a look here if anyone has any numbers to put in the chat or the Q&A.
I've opened the chat and you should be able to do it there if that's easier, folks. So, but
Great,
either
thank you.
should work.
Yeah. Do we have any takers here? Anybody who wants to share?
Barry, there's some in the Q&A. You have an 8 and an
Yeah.
8,
Great.
7
Okay.
and a 9. Someone else said they cared for their mom. The collaboration with the team was an 8, and the experience with the family members was a 7.
These numbers are very high. You know, I wouldn't have given I wouldn't have rated my family or the clinicians I work with is that high. I'm seeing lots of so it sounds like you've all had very good experiences. 7 and a 5 from David. Any other numbers?
Even another, my mom, who was a retired nurse, collab about a 5 and family members about a 7.
Okay. And I see Janet says, my mother's team is great. Experience with my mom is about a 3. I hear you, Janet. I would probably say my experience with my mom was maybe a 2.5. So, but we see a lot of different numbers here, but on the whole, we've given this presentation many times. The folks at ASU are obviously getting along really well with their family members' treatment teams, because these numbers are quite high from our experience. So I'm going to go on and just kind of give a little bit more context here. And I'm going to do this very quickly. So there's a report that comes out every 5 years called the Caregiving in the U.S. report. And the latest report just came out in July. And it found that there are about 63 million Americans who provide some form of caregiving in the course of a year. That's out of a U.S. population of about 340 million. So there's a pretty sizable number of Americans doing this. About a little bit more than a quarter of them are what's called sandwich generation caregivers, meaning they're caring for a generation above them and perhaps 1 or 2 generations below them. And that about half of them are caring for a parent, 50% for a spouse, and then you can see that the other numbers there. Caregiving really is a growing phenomenon. The sheer number of caregivers is increasing every 5-year report. The last time this was done, it was 53 million. So it seems like every 5 years, another 10 million Americans are doing this work, and it's all because our population is aging, and with age, there are more chronic illness, greater prevalence of chronic illness, and greater need for caregiving. Family caregivers do many things. You can see on the slide here, and I'm not going to go through them all. They're not just the companion and the driver, but they're often the person who is helping clinicians understand what's going on with a family member at home, as well as taking information that the physician may be sharing with them and then sharing it with the rest of the family. And they do a lot of home care, clinical care at home, and that could be something as simple as organizing a pill box, and doling out pills, or flushing feeding tubes, running lines. I mean, they're not putting in lines, but ensuring that the lines are running, overseeing equipment. So family members who take on this caregiving role really do a number of things. Mostly they don't realize how much they're going to do at the point at which they sign up to do this, because it's a long journey oftentimes. And as their loved ones decline, they have to take on more and more responsibility for them. There are 2 bodies of research about how caregiving affects caregivers, and one of them is spearheaded by the gentleman on the left there, Dr. Rich Schultz from the University of Pittsburgh, looking primarily at dementia caregivers, and found that spousal dementia caregivers were at very high risk of their own health consequences, insomnia, depression, musculoskeletal problems, and because those caregivers were not taking care of their own health that well, and they were not faring well with their own chronic illnesses, and had higher mortality rates compared to non-caregivers of the same age with the same chronic illnesses. But the gentleman on the right, Dr. David Roth from Johns Hopkins, found that caregivers didn't die sooner, but in fact lived longer, because caregivers have an enhanced sense of purpose. So 2 opposing literatures on caregiving, that is just to suggest that caregiving is a very heterogeneous population, and one that we really need to take take the variety of the caregivers before us into account, and not make broad generalizations just based on the research. I'm going to hand this over to Katherine.
So the 3 of us who were, kind of working together as colleagues, we all experienced these stories that we told in close proximity in terms of a time course. So we kind of, got together and talked about this first informally, and then in preparing this talk to talk about kind of like the challenges for clinician caregivers, and also, some of the ways forward. And this is what we came up with in terms of what the challenges for clinician caregivers would be. Number 1, it's hard to have an objective perspective. I'm sure we've all probably experienced heightened vigilance, or perhaps second guessing ourselves when a family member is sick, in a way that we really wouldn't do if we were more objectively treating someone that we didn't have that close relationship with. In my father's situation, I was secretly sort of hoping that there would be an aspiration pneumonia that could be treated and somehow improve him, and he went back to eating and drinking, when it was pretty clear clinically that that wasn't going to be the case. Self, family, and sometimes team imposed expectations can be very confusing. It can be difficult to know what your role is. In the scenario I described, the hospitalist assumed I was the medical decision maker because of the role I had in medicine, when my father was still very able to participate in his own end-of-life decision-making. And my father saw my role more as an advocate in the healthcare system, but definitely not a decision-maker, or even the one who was the most knowledgeable about my father's health problems. That would have been my mother. Guilt, we have this in bold with a bigger font with 3 exclamation points, because it is real, and it is often, I think, unrecognized. Even if things go the best way that they can, having an influence in these life or death moments, these really, really critical moments with family members, can be a very heavy thing to carry, and can definitely lead to guilt or some degree of rumination on the subject. I think role uncertainty is, kind of a really interesting part of this. There can be, role uncertainty from various angles. Your family may not, they have different expectations of what they might want. They may want you to be sort of an authoritative guide, telling them, what to do, or they may not want that. Do they want you to be an expert, providing clarification and answering questions? Or do they really kind of want you to be more of a hands-off supporter? They just want you to be the son, daughter, spouse, etc. And then sometimes even more difficult to predict is what the treatment team would want or expect from you. Are they going to welcome your presence and be glad they can obtain information quickly from you? Or are they going to see you as obtrusive and potentially either taking up their time or undermining their authority? Next slide, please. And the role of the clinician caregiver can get even stickier if you perceive your loved one's treatment is not going well, or if their judgment decision-making capacity becomes impaired over time. Both of these scenarios might make you feel more compelled to be more assertive and be there as sort of not just a family member, but as an expert decision maker. Another example of this is that over the years, my mother has had recurrent small bowel obstructions and has so far always turned the corner without surgery. But in recent years, I found myself pushing back against her surgeons if she's admitted to not her primary treating hospital, if they wanted to take her to the OR in what I would consider too soon a time frame. So this has definitely caused me some discomfort because I'm kind of, out of my bounds of my expertise, but I do bring a lot of experience from my mom's prior episodes to this decision. So when a family member is critically ill, it's hard to know where the boundaries really should be. We can move to the next slide.
Yeah, I'm going to skip a slide. I think we'll skip the we'd like to get your feedback. Actually, let me do that. So someone is unmuted and is making a lot of noise. If you could potentially, possibly mute yourself, that would be very helpful. Thank you for that. So we are wondering, we just described some of the challenges of being a clinician caregiver with both the patients in the clinical team and also with your own family. And we're wondering if this resonates with any of you, and if so, what have you found has worked in your interactions with your family members, treating professionals, and what would you recommend to others as an ideal collaboration among not just the clinician caregivers and the treatment team members, but also the patients as well. So does anybody have any thoughts about that they'd like to add? Any thoughts? And if it's too tough to put in something in the chat, I mean, I'll give you a couple moments. There are a couple questions here. And MJ Hendricks is asking maybe all of us, did we move in with a family member or did you follow up daily periodically? And I would say for all three of us, we followed up regularly, but we didn't live the person we were caring for. And I think it matters. I do think if you're living with a person, it's much harder caregiving in general. Jackie Medlin says it's going to be an answer at the end, but given the dramatic increase in caregiving needs throughout the US, are there any policy changes? And I will answer that at the end if we have time. And let's see some of the answers that we've just received. So Rena says a collaboration between family carers and clinical staff is very important because each has their own role in providing care for the patient. And so I guess the question is there what would such a collaboration look like for it to work as well as possible? Any other thoughts about that? Otherwise, we'll provide some ideas and maybe have you respond to those ideas. Okay, I see something else in the back. Wendy says that Katherine mentioned the clinical team needs to stop ignoring the patient for care input. Absolutely. I mean, I would think that would be just a basic ethical principle that we extend the right of self-determination to our patients if they are cogent and are, have the capability of making decisions for themselves. We should never go around them by asking their family members just because their family member happens to be a healthcare professional. So that's a very, very good point. Um, any other ideas of ways of making this collaboration go better? Teresa and Derek say, excuse me, let me get back here. The healthcare system time constraints provides challenges, and absolutely, and I'd love to hear more of your thoughts about that, Teresa and Derek. What kind of challenges they may be. Janet says, I wish that clinical team members would not automatically jump to interventions. My mom is 91 and not a good candidate for for any anesthesia. Yet I have to repeatedly say, let's back up and bring the back to what is realistic with someone in her frail condition. And I would say, Janet, that makes sense from a clinical perspective. It makes sense as a family member. But I guess the question is, when you say let's back up, are your mom's treating clinicians willing to back up, or do they feel like you're interfering with the treatment plan they have for your mother? Rena says, for example, in interventions, each person has their own responsibilities. The family provides spiritual and cultural support. Nurses offer nursing care, and doctors provide therapy related to disease management. And I think that's correct, Rena, except that if you're a doctor, I'm going to use Katherine here as an example. When she's talking with her mother's um, her mother's doctors or other healthcare professionals, Katherine is not simply providing spiritual and cultural support to her mom or to her dad. She is also listening with a knowing ear, knowing what good clinical decision making looks like, and maybe even having some of her own clinical ideas about how the treating professionals ought to be treating her parent. Um, so any other thoughts before we go on? Yeah, I just want to say, and I see one new message here, but I'd love Janet to hear more about what, when you say let's back up, do they listen? Um, Rena says, I'm a nursing student. I'm also doing nursing care for family members. And I would say, so Rena, that poses a couple questions. So are your family members interested in your perspective, in your point of view from what you're learning, um, because you now have this special status in the family, or are you also, or do they feel like they just want you to be a daughter or a just a family member rather than have this special information that you've gained through your nursing training? So these are the kinds of questions we're interested in trying to answer. So I'm going to go on to the ideal collaboration. I'm going to turn this over to Kim.
Thanks, Barry. We had another response too. Older brother had power of attorney, which didn't work well with dad's preferences. Is there a precedence if I'm a licensed caregiver? There's not. The power of attorney takes precedence. So it's, the family member's decision based on their power of attorney, or, just next of kin if there is no power of attorney that's written up. So being a licensed provider doesn't change who gets to make the decisions. So, we thank you all for your input. You have all made some really great points. This, in an ideal world for collaboration, again, after we all sat down and reflected and thought about this and talked about it, it was really that mutual respect and appreciation all around. While it would be nice to have those defined roles, it's much more fluid than that, and it definitely depends on the situation. But thinking about the clinician caregiver or the clinician caregiver respecting the autonomy of the family member appreciating the clinician caregiver's input for the collaborative team. The clinician caregiver's input is welcomed by the collaborative team as an informed observation, and then the clinician caregiver respecting the perspectives and expertise of the collaborative team, right? So this is ideal, and it doesn't always stay in this black and white, right? Many of you have talked about issues that you've seen on your own side. these lines can become very blurry and have, come with their own challenges. I see some other comments as well. Rena had responded and said, to tell the truth, they are very satisfied with me, and each of them have different illnesses. For example, my father is blind and has psoriasis, cardiomyopathy, hypertension, and diabetes. I provide continuous care for him, and they feel very good about my knowledge and the way I provide care. And that's, that goes with this ideal collaboration, right? You defined roles as the caregiver and the family member. And, how does that fit into those visits that you may go to with your dad, and the other providers that you're speaking to. So it's it's always it can just, the line can be blurred at times. You can go on to the next slide, Barry.
Yeah, it looks like they're Sierra Maki put some things in the Q&A. Do you want to respond to those as well?
Oh, sure. I'm in the middle of a caregiving role with father and mother, both with dementia. One thinks it's 1937, the other does not remember conversations from 1 hour to the next. That sounds like it can be very challenging. And then, not only just taking care of them, but then how do you maintain what their wishes are? And, did you even have that conversation to understand what their wishes were before their change in mentation?
Yeah. Could I jump in,
Sure,
Kim?
sure, please.
Because and CR, I'd be really interested in your point of view here, but in my idea, my idea of your family situation is it's actually it's awful that your parents are both suffering from dementia, and I went through it myself. It's awful, but it's also clearer and neater when they're clearly not competent to make decisions for themselves. And obviously we would want them to have an advance directive and have their wishes codified in a document that we could refer to later. But if we don't have that, and it's clear that they're unable to make decisions for themselves, and that puts you in a role of authority for them. And while that's a heavy responsibility to bear, it's also clearer than a situation where someone may be in the early stages of dementia and may be still making decisions for themselves, but maybe not making good decisions for themselves. So they still would pass muster with some sort of evaluator, whether they have legal competence, but but you have concerns about the decision that they're making, and you're trying to have some influence on them, and they either may or may not want that influence. Thoughts about that, Katherine or Kim?
Barry, they went on to add that the family members making important decisions related to physical safety. And I think that becomes challenging, right? Because now they don't have the capability of signing what you need them to. And then they're making decisions that you may not necessarily agree with. So how do where do you define that role of, and this is where it's tricky, right? Because there's no clear line of what that looks like. And it has to be, we'll go on to talk about that actually in a little bit, if you hold on for another slide or two. There's another comment here, just curious, are there any formal partnership agreements out there for clinician caregivers? It might be helpful in an upfront collaboration with care teams in situations where you are appointed as a POA. I don't know of any formal partnership agreements. Are you familiar, Barry?
I'm not, but I mean, I think having some agreement with the treating professionals about what role you're going to play, and especially one that you've already vetted with a family member, the patient, I think would be ideal. But we'll talk about that more in a moment. But are there any formal documented partnership agreements? Not to my knowledge.
And I think, as we've given these talks, we've come to realize that these are things that we need to do on our own, is set up those boundaries from the beginning. And again, that's what we'll go on to talk a little bit about. If you want to go to the next slide, Barry. So now that we've established some challenges and Now that we've established that list of ideal situations, let's look at some challenges and barriers that caregivers can expect to come across, as well as the um, aspects of that, the aspects of the ideal team. How do we overcome these challenges? And we ended up breaking it down into three basic concepts: expectations, diplomacy, and guilt. So looking at this first bullet point, establishing expectations are key for both the family and the caregiver. This is tough because we can't always predict the future, know exactly what we're getting involved with. However, it's important for us to set up those expectations from the beginning, to reflect on what your role will be and have discussions with the family, and reevaluate. Something might not be working. I had a family member that had asked for support, and as things started going, I was the in-law, and the children's or the children of the family wanted wanted to have more ownership. So I had to reevaluate and back off a little bit. And that was, those changes are going to happen. The next 2 points are in dealing with your family member's care team, where you're navigating expectations and diplomacy. This is a crucial aspect of this. You know your family member, you know how they'll react or behave. However, as we've stated, it can be tough to remain objective. Understanding your role with the care team will help guide your decisions and hopefully allow you to be more present as a family member and not as their caregiver or clinician. There may come a time when you don't agree with the decision that the care that the team is providing, but how do you remain respectful while also advocating for your loved one? Knowing what your boundaries are will definitely help you navigate through this space. And then finally, that guilt comes back again. How do we deal with our own guilt? For most of us, we're going to feel like we never do enough. But a lot of this is drawing the line between what we can live with, but also encompassing the autonomy of our loved one, as well as the judgment of the care team. So it's this fine balance that we need to kind of establish the boundaries of, so that that guilt doesn't take over. So hopefully with the help of setting up expectations and walking that line of diplomacy, you'll be able to mitigate that guilt. And Barry, I think you can go to the next slide. We ask some ideas of how you may have overcome the challenges of being a clinician caregiver.
Let's skip it. Let's just.
You want to skip it?
Yeah, let's go. Let's go
Okay.
on. And I'm going to hand this back to Katherine to finish up her portion of her family story.
So my dad, to remind you, he had the swallowing difficulties. He was admitted overnight to the hospital, and then he was transferred to an inpatient hospice unit. They were absolutely wonderful there. They sort of restored his dignity at the end of his life, and he passed away 4 days later. So the lessons that I kind of learned was that having, we probably speaking to the choir here, but having a copy of my father's living will was really crucial in deciding against a feeding tube. I had to push back forcefully at times against providers who didn't want to include my father in end-of-life discussions. Not that they were like villainous. I'm sure they were just pressed for time, but that's something to be aware of. And the responsibility of being involved as a clinician caregiver, like I said, is a lot to bear and can really affect the grieving process. Next slide. Turn it over
And this was my dad about a month before he passed away. My parents decided to enroll my father in a research study earlier in his disease process, when he was still making his own medical decisions. But later on in his care, probably maybe a month or two before this photo, his study required a spinal tap, and my initial instinct was no way. He was too fragile at this point. As someone had mentioned earlier, right? Having procedures, didn't make sense to me. But I needed to take a step back and remember why my dad signed up for this study in the first place. He knew that this study wasn't for him. It wasn't going to change his care. He was doing this for other people. He was doing this for me and my sister. It was what he wanted and it was how he lived his life. So I ended up encouraging my mom to agree to the procedure, and he did go through with the spinal tap, and he was able to do it. Um, but these decisions only became more difficult as the care moved along. The timing of starting hospice and placing him in long-term care, and then eventually making that decision to start morphine. No matter how much of this was based off of my dad's own wishes, um, you still question every decision and wonder if you did enough. Hopefully, reflecting on the ways to overcome the challenges that we talked about earlier will help to alleviate these feelings of guilt and provide peace through your journey. Barry, go ahead.
And here's me and my mom again. And just to remind you, we would be arguing in front of her primary care physician, and it became impossible for him to figure out what was going on. And it was a very unpleasant experience for me and my mom, let alone her internist. So we worked out a compromise where I felt like I was doing due diligence for my mom. I was providing information to her primary care provider that I did not trust that she would provide because she wouldn't tell the primary care provider that she had been falling. Maybe she didn't remember that she was falling, or maybe she was trying to save face by not sharing with him that she had had falls. So I felt I needed, as her son, and not just as someone who's a psychologist working in family medicine, but as her son, I felt like I needed to rat her out a little bit and provide information about her, even if she didn't want that information to be shared. So but I also wanted to make sure that my mom had the autonomy to have a relationship with her provider that was not being affected by me, where I wasn't present and she could just talk with that provider. On the other hand, I also wanted to have a relationship with the provider where I would know what was happening because I couldn't trust that my mother would then share with me the information about what had gone on in her medical visit. So with all those complications in mind, we worked out this compromise. At the beginning of my mother's primary care visits, I would attend for the first few minutes to do almost like a report of systems. I would say, my mom saw her dermatologist, and this is what happened. My mom saw her cardiologist, this was what happened. Because even though those records the reports were in the electronic medical record, it was still a good thing for me to kind of run down what was happening, especially if there had been any kind of medication changes. So having discharge that responsibility, I would then leave and go sit in the waiting room. My mother would then have her visit alone with her PCP, which was made her feel good that she had a relation with her PCP that was not interrupted by me. And then after that, the PCP would leave my mother in the medical exam room and then come out into the waiting room, kind of give me the high sign, and then wave me into his office, where he would then briefly share with me his impressions of my mother and what the plan was for her going forward. So that I would leave, then he would go back into the medical exam room and finish up the visit with my mom. But by the time my mom came out, I would basically know what the plan was, whether there's going to be any kind of change in the plan. And so again, I didn't have to rely upon my mom to report those things to me. This was actually in the days before there were medical visit summaries, which would have helped in this matter. But the fact that physician came out and shared this information with me made a big difference. But this was the fact that we had this kind of convoluted switching of parties to the visit was I think just an indication of how the provider was trying to meet my needs, trying to meet my mother's needs. I was trying to meet my mother's needs by staying out of the way, but also trying to meet my mother's need for having a primary care provider who was as well informed as possible. So that's the arrangement we came up with. So I'm going to hand this off to Katherine. Actually, it's me. We're going to talk about some personal lessons learned.
Barry, it
Um,
is quarter up. Do we have time?
um, well, we'll do this really fast. We'll take 3 minutes to do this. I could be a little bit of a hothead, and I could get very testy with my mother as well as with some of her clinicians. But for me, it was very important that even if I disagreed with the clinicians, I had to be respectful of their expertise and that they may have a more objective view of my mom than I did. Catherine?
Yeah, I mean, I guess the flip side of that is, kind of just trust your gut and don't be overly deferential, even if a clinician is like seems to be more experienced or has expertise outside of yours. You know your family member, and you should not always be deferential to them.
And, guilt has come up multiple times here. It's speaking up or not speaking up can cause guilt. I had a situation where my grandmother was a DNR, DNI, DNH, and she ended up in a hospital intubated. And I was the first one to arrive. And even though I was not the POA, they knew that we were not happy with the care, and they allowed us to pull the tube before anyone else got there. And then, living with that guilt of, did I do it too soon? Should I have waited for my mother and my uncle to get there? And it all worked out. Everyone was able to say goodbye to her. But it's, when do you speak up? When don't you speak up? And knowing that space can be double-edged. Catherine?
Yeah, I mean, at the end of the day, don't second guess yourself. You're at the end of the day, your role really is primarily a family member. You should allow yourself the time and space to grieve and just trust that you've done, all that you can and the best that you can for your loved one.
Yeah, I think that's what we all want, that we've done the best that we can using all of the knowledge that we have available to us, but also not being overbearing on our family members' treatment. So I'm going to actually just take a look at some of the chats, comments, and some questions. I see Kenneth wrote something very interesting here. He said, I had conflict with my mother's family physician. I was in medical school at the time. She had some chest pain that I witnessed. Her physician immediately referred her for a cardiac cath, which was a newly available procedure in Phoenix in the 1980s. Based on my observation, I pushed for a pulmonary evaluation and was told I was a cocky medical student and needed to butt out. Um, this certainly sounds like the kind of thing that we're talking about today. Um, and I'm kind of, it says the cath was negative, but there was a suggestion of MVP. She was placed on propanolol, also new to the market at the time. This triggered a bronchospasm with undiagnosed COPD so severe that she spent 3 days in the ICU, barely skirting intubation. She would soon also be diagnosed with lung cancer that, in retrospect, was barely detectable on the chest X-ray, finally obtained at her ICU admission. So, I mean, that's exactly the kind of situation I think we all fear, that we know our parent, we know our family member better than the treating clinician who only sees them for a brief window of time. We see them all the time. Our observation and our history with them give us more knowledge of them. Yet we don't want to be stepping on the clinician's toes. And in this case, the treating clinician just blew you off, and in fact, and I'm sure that was very hurtful, and put your mother in a position where her health was jeopardized, seriously jeopardized, because of that clinician's disinterest in entertaining your point of view. Catherine, do you have any thoughts about this one?
Yeah, I guess that's how they were allowed to talk to med students in the 80s. As someone who teaches med students now, I don't know if I could speak to them like that. But yeah, I mean, I'm sure there's a reason that story stands out so vividly in your mind, is that, your gut was telling you it was the lungs, and turned out to be very much so.
Yeah. Are there other questions that we should take a look at? I mean, there's certainly a lot of comments in here. MJ Hendricks says, when I was a young EMT, the local physician who took over as caregiver for his wife did a remarkable job keeping her comfortable until her passing, but he never recovered himself and eventually ended his own life. Oh my. It is important for all caregivers to have support before, during, and afterwards to prevent this kind of loss. Absolutely. And I would basically say that, the we do read in the newspaper occasionally about these murder suicides where someone, the caregiver, will murder the person they're caring for, usually somebody with very advanced dementia, and then kill themselves. Those are really horrendous stories. They get a lot of attention because of how horrendous and also how rare they are. But caregivers often have their own health consequences from caregiving, but they don't usually end their own life as a result of the stress of caregiving. So that's a very alarming story to hear. Um,
Very earlier in that, the same person wrote that in the Washington area where they live, the local city community centers have periodic caregiver support groups. They're very helpful in networking, guilt management, and sharing coping and care strategies, as well as caregiver resources in the region. And I think these are really important, these community spaces for people, specifically caregivers, to be able to come together and support one another. And I think we're seeing more and more of that. But then, this clinician aspect of it for us plays a different role that some people might not understand. So being able to share these stories for the three of us was really helpful and support. Barry or Catherine, anything to add to that?
I mean, I think that, the fact that we have community resources like support groups to support caregivers, and that just as a greater societal acknowledgement of the importance of family members playing this role is crucial. And those of us who are clinicians playing this role, as you pointed out earlier, Kim, that playing this role then gives us greater empathy for our own family, the patients that we see later on and their family members, because having been in this role, it's a really tough role to be in. Um, I see two comments here. One is Julie says, I'm not there yet. My parents are in their 70s and I am their POA. Do you have suggestions on discussions that I should have with my parents beforehand? They already have a living will. I am referring more to the relational part. Kim or Catherine, do you want to answer that?
Yeah, I was just sort of thinking about this, I think after what happened with my dad, my mom went on to have her own illness. And I was just a little bit more equipped to be like, what do you want me to do in this appointment? You want me to come to this appointment? Like, do you want to start talking? Do I want to start talking? Like, these things are going to fluctuate so much. There's not like one script that we are going to follow during the duration of an illness, but just being able to have an awareness that your role is going to change, just having like a quick conversation with the easier somewhat with the family member about what you want your role to be in that moment.
Yeah, I think that's a really good recommendation, Catherine, that and Julie, you may consider that when you begin attending your parents' medical visits, when that happens, to have a specific conversation with them beforehand about what role do they want you to play. Do they want you to talk? Do they want you to just observe? But to really work all that out beforehand so there's no misunderstanding. There's one last question here from Jackie. She says, given the dramatic increase in caregiving needs throughout the US, are there any policy changes on the horizon at the state or federal level? And I'll answer this, what is a very complicated question, very briefly. There have been policy changes over the last 5 to 7 years. There is something called the RAISE Committee, RAISE Act, which was a blue ribbon panel that developed all sorts of recommendations for how the federal government and state governments can better support family caregivers. In 2022, the Administration for Community Living put out a report called basically supporting family caregivers. It was filled with ideas of policy and programmatic innovations to help support caregivers. I've been doing this work with caregivers for 30 plus years, and I'll tell you that caregivers are much better recognized and much better supported than they were in the past. That said, as with our aging population, more and more people are stepping into this role and feeling completely lost at the beginning. And the more as treating clinicians, the more we're aware of folks stepping into this role and what their needs are and the kind of direction that they need, the better those folks are going to do. And so we all have to see the work with family members as part of the work that we do with patients. That if we guide family members, help them do a better job caring for the patients, then it enables our treatment plans to be more effective. Catherine and Kim, any last thoughts about what changes you would like to see or might in the future?
We just have a couple other comments on them. We get
Yeah.
to all of them. One is, what do you do with the family member, where am I seeing it, who's fiercely independent but needs help? It's like we need a whole nother hour to address that. But I mean, I think that is very universal. Barry probably has some wisdom on that, but just recognizing that like that's the case in almost every caregiver situation, and that leading with like respecting the individual's autonomy is probably the best place to kind of lead from.
Yeah, I just wrote an op-ed in The Guardian that appeared 2 days ago. If you put in The Guardian, just put into the browser The Guardian Barry Jacobs, the op-ed will come up, and it's on this question of how to work, particularly with a parent who needs care but doesn't want care, and how it can be very, very difficult, but how you have to maintain empathy and as Katherine just said, respect for their autonomy, even as you're trying to ensure their safety. Pretty tough stuff, but at least you can read a little bit about my family story with my mom, who was not an easy person, and she was a pretty tough customer in my mind. So, anything else, Kim, that you'd like to add?
There's a couple more things that are popping up. Someone suggested a clinician caregiver support group. I think that would be great, and maybe something, to consider setting up in the facility that you're working in or the group that you're working with. Maybe even in the school system, right? You're in a space where you might have other providers, or soon to be providers that we can, form a space to have these conversations with. I think it's really important for having room to be able to talk openly about this, because one of us, someone's gone through something that you're feeling, and may have some ideas to support. So, take that lead and set it up in your own space. I think that's a great idea.
Yeah. Katherine, any last thoughts before we turn it back over to Matt?
No, I just think I appreciate everyone's engagement and participation. I feel like we could go on and on. Thanks.
Yeah, for sure. Thank you all. Matt?
Thank you, Barry, Katherine, and Kimberly, and thanks to all the participants, all the attendees for the warm and personal insight and comments. This has been fantastic. If you have not already do so, please register your attendance using the self-check-in link posted in the chat, or so that we can have accurate record. We encourage you to follow the College of Health Solutions on social media, where you can learn more about other opportunities like this one. This is our last Health Talk webinar for the year. We will continue in January. More details and registration are available at asuhealthtalks.com. Thank you again, everyone. Have a great rest of the day. Bye-bye.
Thank you all. Good luck.